there. Can you see that? Yep. Good morning. Well, thank you very much. I'll be presenting the second presentation today. My title was Breaking the Barrier, and sticking in with the Ocular Oncology and Pathology theme. I don't have any financial disclosures either. So my objective this morning, first of all, is to describe the clinical features that we may see in carotid melanoma with extrascleral extension. I'd like to talk about some of the histopathological features seen in extrascleral extension, and finally discuss the options available to managing patients with this extension. So our first case is a 51-year-old male. He was referred here as a second opinion for right carotid melanoma. He himself is asymptomatic and was previously seen at Duke. So as you can see, his vision is pretty good in both eyes. He's 20/20 in the affected eye, left eye just a little bit worse, but overall pretty good anterior segments. And of note, his medical history, he was diagnosed with blood pressure just earlier on this year. His family history of note, his father had prostate cancer. And the next slide should be his fundus photo. So the first thing I want to point out is a fundus photo of his right eye. The optic nerve looks pretty good, the blood vessels look pretty good, and the central macular area looks pretty good. But of course, the most striking thing you see here is his pigmented lesion. And I thought one of the useful things to always remember when you're trying to decide, is this a benign lesion or a malignant lesion, is to go through a very helpful mnemonic that Shields and co-workers have described early on. And that mnemonic would be to find small ocular melanomas, and they updated it to say using helpful hints daily. So just briefly going through some of the features, thickness is something. So if on BBCh scan measurements, the tumor is more than 2 millimeters, or the lesion is more than 2 millimeters, then we're going to be a bit more suspicious. If there is any associated fluid, subretinal fluid, then you're going to be more suspicious. Our patient didn't have any symptoms. He did, however, have evidence of some orange pigment on the lesion. And as we can go back to look at the fundus picture, his lesion was actually adjacent to the optic nerve. His ultrasound, I'll show you those in a second, did demonstrate acoustic hollowness, and there was no evidence of any halo or drusen. So if we go back to his image, you can see clearly that the lesion is adjacent to the optic disc. There does be orange pigmentation within the lesion, and we can determine any evidence of any subretinal fluid here. So this was his A scan, and you can see that there is evidence of some low reflectivity here. And as all previously described, the two differences between a melanoma and metastasis, this would be more fitting. But the most striking feature here is the B scan here. So this is his B scan, and first of all, I'd like to point out this is his melanoma. This is a nice dome-shaped lesion with acoustic hollowness here. But the most interesting feature is this, this feature here, which also shows almost like a second lesion outside the sclera. So this acoustic hollowness here is similar to what you see in his tumor. And this led us to believe that this indeed is extrascleral extension. So what about the measurements? So his tumor was more than 2 millimeters, it was 2.1 in thickness, and the extrascleral extension portion was 1.8 millimeters. So what other factors play into this patient's management? Well, he's also a doctor, and as we all know, doctors can make great patients, but they can also make bad patients too. And my own personal experience is that some physicians are very happy to take on board your advice, and equally you'll have some great doctors that may want to explore other options available to them, and that's obviously their right, and it's important that they have that right too, but it's also equally important that we all agree on a focused management plan. Not only that, this patient, his subspecialty is he's an oncologist, so he actually has a wide knowledge of what's going on in his particular condition. So I'm going to move on to, at this stage, what options do we have? So our options at this stage include radiation. So we can have local radiation, including plaque radiotherapy. or he can be referred for proton beam radiation. And as Ol mentioned earlier, this is certainly more expensive and more time consuming. Obviously, removing the eye would be a good option. Observation really would probably not be suitable in his case, though we do have some patients who may be in certain age groups or have other coexisting conditions and have small melanomas, and they may be able to be observed without any problems. So I'm going to move on to case 2, just to show you a few more cases that we've seen here at Emory. The next case is a 36-year-old female. She was referred here for a carotid melanoma. She previously had 3 episodes of TTT treatment in San Francisco. She also has pretty good vision. And when she rocked up here in 2012, this is her fundus photo. As you can see, she's got a very well-treated carotid melanoma here. You can see that the macula appears to be well spared, and hence the reason why she's got good vision. There's nice scarring here and RPE pigment atrophy due to the radiation around the tumor. And at that time, in 2012, her thickness was approximately 3 millimeters. So over the years, we've been following her up, and then we move fast forward to 2018. You can see that the tumor itself hasn't really changed too much in fundus appearance, though there does appear to be more pigmentation around the areas of atrophy here. But what is striking is that when we go back and look at her measurements, you can see back in May 2017, it's kind of jumped to 3.2 millimeters in thickness, and in June 2018, it's gone up to 3.8. So she was followed up again 3 months later, just to first of all confirm when you do ultrasound for lesions, it's very important that we have very good, consistent working people, as we do here in Emory, that can measure tumors. And it's very important that you actually bring them back to confirm that these dimensions are indeed true. And true to form, back in September, 3 months after June, fundus appearances are very similar, but you can see that the tumor certainly is 3.7. So if you go back to 2012, it's got a 0.7 millimeter increase in thickness, though that is over a 6-year period. But the interesting feature here is that this tumor is, if you can imagine the outline of the tumor dynamics of the contour of the sclera, this appears to be invading into the sclera. You can actually almost see a little nugget of increased thickness here. So based on the fact that this patient's probably had interscleral extension of the tumor and an increased demonstrated size of the tumor on ultrasound, we discussed options with her, and she decided to undergo proton beam radiation treatment, and therefore was referred to Jacksonville in Florida to have this done. And with correspondence back from the doctors in Florida, she's doing quite well post-treatment. So our third case, seen here at Emory, is a 52-year-old female. She presents here with a right-sided carotid melanoma. Her scenario is slightly different. Her vision is quite poor, and she has a pupillary defect, and you can see why. So you can see she's got a very large lesion here, not only surrounding the optic nerve, but also affecting the central macula too. The referring physician referred her here to Emory to see if this patient could have localized plaque radiation treatment. And then this is a good teaching point that Dr. Christoph wanted to point out, that the referring physician's MRI scan did not show any extrascleral extension. And I think it's very important to always perform your own imaging at your own center for a number of reasons. Number one, they may not necessarily pick up signs, but equally, patients' conditions can evolve over time. So it may be true that the patient did not have any extrascleral extension when they were seen by the referring physician, and over time, the tumor can obviously evolve. And this is, again, acoustic hollowness seen here. So due to the patient's poor vision, she decided to undergo enucleation. This is the gross imaging scene of the tumor. So you can see the tumor quite nicely here. This white portion here is the sclera, and you can see that it's broken through. The tumor has broken through, and this is the extrascleral portions. It's quite a large tumor here. These are very, these are H&E slides. at a very low mag. And just to reorientate yourself, this is the optic nerve here. This tissue here is the sclera, and this here is the tumor. And you can see clearly that this tumor has eroded through the sclera. Demonstrated here very nicely. These are slightly higher magnifications, 25x, and the next one is 100x. And these show the typical epithelioid type cells seen in malignant melanoma. And she's doing quite well. She's doing 5 years since her enucleation. She's doing well. A follow-up, no evidence of any metastasis. So enucleation for her was a good option for her. So what evidence do we have outside? Well, there is very little evidence out there. They're mainly consisting of single case reports. Shields and co-workers in Philadelphia back in the 70s and 80s looked back at more than 2,000 consecutive cases of melanoma, and they reported an incidence of approximately 5.8%. So it does exist. These are a couple of interesting cases seen in the literature. I do apologize for some of the quality of the images, but these are taken from the publications. This case was a 68-year-old male from Boston, and this patient clearly presented with an orbital mass in his left eye, seen quite well when he looks to the right. And this is the imaging that you can see associated with it. Highlights it up very nicely. This is the MRI scan. So this patient underwent a transconjunctival biopsy, which confirmed, again, this patient had indeed melanoma. And again, these are the typical epithelioid type cells. So this patient underwent a combined treatment. They decided to treat this patient with a transconjunctival orbitotomy, where they removed the orbital portion of the tumor. And they separately then underwent proton beam radiation for the intraocular component and the intrascleral portion of the tumor. Due to their local protocol, they also gave them systemic interferon. And from the publication date, 8 weeks post-treatment, the patient's vision maintained quite well. And from the 6 months follow-up, they were doing quite well too. This case is quite unusual. I thought this was quite an unusual case. This is from France, published in 2016. So this was a 48-year-old female. She interestingly presents with a sudden loss of vision in her right eye. Her anterior segment examination was quite normal, though obviously her vision was quite poor. Basically, I believe they didn't actually have color fundus photos, so these were actually images taken from the Heidelberg Spectralis OCT. The left eye fundus was entirely normal, but the right one, what this is trying to demonstrate was that they actually had evidence of optic nerve swelling. So they performed further investigations, including an angiogram, which they described as leakage with associated subretinal fluid. So their working diagnosis of what their thoughts were, this was probably optic neuritis. So they commenced them on intravenous and oral steroids. And of course, then the vision did improve up to 2020. Subsequently, though, the patient did complain of a continued visual field defect. And as you can see here, there appears to be more of a superior type arcuate type scotoma in the right eye. But as part of the workup for optic neuritis, they did undergo further MRI imaging. So without contrast and with contrast, you can actually see there's a very nice lesion highlighted here, and this is with contrast up here. So they then performed further ultrasound B scan, which they confirmed that there was an extraocular mass. They did do further systemic evaluation, and they ruled out pretty much most infections, inflammation, and neoplasia. So they determined this was a compressive optic neuropathy. They did perform further follow-up imaging with ultrasound, and I'll have the images in a second, which did show that the lesion did increase in size. And so here are the ultrasound images. So this is the extrascleral portion that they noted at the first ultrasound. And they did notice that 6 months later, that the tumor had increased in size. And this, at this point, the fundus did show a pigmented lesion. So needless to say, this patient underwent an enucleation, and here you can see the extrascleral portion of this tumor. So this patient also had external beam radiation treatment to the orbit, but sadly, 10 months after the enucleation, they developed metastasis to the liver, and the patient subsequently, unfortunately, passed away 7 months after the metastatic diagnosis. The Shields and co-workers, again, published in 2000, their own thoughts on using plaque radiotherapy for managing tumors with extraocular extension. It was a retrospective study of 17 patients. All their tumors of the extrascleral component were less than 3 millimeters thickness. And at 63 months follow-up, they determined that was good control of local disease. So they concluded that localized plaque brachytherapy appeared to be a reasonable treatment for select cases of tumors less than 3 millimeters in size. So back to our original case, just to summarize, this gentleman here, 51-year-old male, he's a physician and an oncologist with very good vision in both eyes, with a 2.1 millimeter thickness tumor, so that would be a medium-sized tumor, and extrascleral extension of 1.8 millimeters. So what options will be offered this patient? So going back to our original options, enucleation, radiation, probably not observation in this case. So we elected to offer enucleation for this patient, despite him having good vision. It's important to note that Duke also recommended an enucleation. So why did we here at Emory recommend enucleation? Well, first of all, the tumor, as you recall, is very close to the optic nerve. So there may be surgical difficulties when you're inserting the plaque, and the plaque may tilt during surgery placement, and therefore you may not necessarily radiate the tumor optimally. And therefore, that can possibly then lead to a higher risk of metastasis. And of course, there's always an increased risk of optic neuropathy for the patient. So the patient himself decided that he would like to seek a third opinion, and therefore he chose to go to Boston to see a specialist there to see whether or not proton beam radiation may be a better option for him. And we are awaiting back correspondence from Boston to see how this patient has decided to proceed with his treatment. So really, in conclusion, carotid melanomas with extrascleral extension are uncommon, but there are some sight-preserving treatments available to them. Treatment should obviously be tailored to the individual patients, and certainly patients with poor visual potential should really be recommended an enucleation. And the final tip is always to perform your own imaging, as you can't really rely on others to do your work for you. And I'd be very happy to take questions.